Today my topic is dyslipidemia, myths, truth and magic. So we have various opinion about dyslipidemia management, and there are different school of thoughts. So I formulated my lecture entirely depending on scientific research evidence published by American College of Cardiology and European Society of Cardiology. So let's move on to the topic. So what is dyslipidemia? We all know it's a disorder of lipid and lipoprotein metabolism. The three key features are elevated triglyceride, LDL, and reduced HDL. It is an important modifiable risk factor for prevention of coronary artery disease. So when a patient comes to you with a lipid profile, it is not about writing a statin to that patient. We have to know why we are doing that. So what are the risk benefit for the patient? So when a patient comes to you next time, what are the things that you have to ask for, look for, and what is the ultimate aim that I am going to achieve in this patient? That's what we are going to discuss today. And over the course of lecture, I will stress some important points to you as we go on. So there are two types of dyslipidemia. First one is primary and the other one is secondary. What is the concern about the dyslipidemia? It is a strong associated risk factor for the genesis of atherosclerotic cardiovascular disease. And atherosclerotic cardiovascular disease is a major killer in the world. So our aim is to prevent this. So it's the coronary or atherosclerotic diffuse vascular disease in the form of either a stroke or major cardiovascular event or peripheral vascular disease. So the ultimate aim that you have to prevent one of these. It is the total cholesterol. That is one of the important things that we have to know. The total cholesterol and LDL increase throughout the life. It accumulates in the body. So as we age, there is cholesterol and LDL deposition in the body. It is the problem, they say, 1/3 the Western world. But here, our problem is adapting to Western lifestyle and diet. So that is our problem. It's a complex disease caused by interplay of genetic, diet and lifestyle. So you can't point out what could be the cause for this. It's a complex disease. Okay, what does dyslipidemia do? It causes atherosclerosis. What does atherosclerosis do then? It either end up as a coronary artery disease or peripheral vascular disease or a stroke. So now the common and the popular term is inflammation. So everything is about inflammation. So what happens is when there are risk factors like dyslipidemia, diabetes, smoking and hypertension, it causes inflammation in the body. That inflammation causes oxidative stress and endothelial dysfunction. That ultimately end up as a cardiovascular disease. Okay, so while we are talking about dyslipidemia this much, we can, the important thing is we have to prevent the end results, because treating dyslipidemia is cost effective than treating the end disease. Because when the LDL accumulates, you get coronary atheroma. Over the time period, when there's a coronary atheroma, coronary blood reserve reduces. It's because of that there's an ongoing subclinical ischemia. So your patient might develop either systolic heart failure or diastolic heart failure. That is one subset of patients. If the coronary plaque which builds up ruptures, the patients end up with MI. When they have MI, you have to treat MI. And as an end result of MI, patients end up with heart failure. Heart failure is very costly for the patient because of the drugs, repeated hospital admissions, and also when we go on for device therapy in young patients. So treating the heart failure is, treating the dyslipidemia is almost always very, very, very cost effective for a nation rather than treating young individuals with MI, stroke or heart failure. So that is our aim. Our aim is to prevent the end result of dyslipidemia. Okay, so as you all can see, there's a 10% reduction in total cholesterol causes 20% reduction in atherosclerotic cardiovascular disease. 1 milligram reduction in LDL cholesterol causes 1% reduction in cardiovascular disease. And 1 milligram increase in HDL causes 3% reduction in cardiovascular disease. So we have to know some figures. So the prevalence it is different. The prevalence is different in different subset of communities. It is the high prevalence in South Asians and Black African. Also, it is highly prevalent in patients with premature coronary artery disease. That is coronary artery disease occurring before 55 years of age in men and 65 years in female. Okay, it is a part of metabolic syndrome also, because nowadays a lot of young children and teenagers, young adults present with metabolic syndrome. So we know lipoproteins are 5 classes. I'm not going to touch the basic physiology and pharmacology because we all can read it up. I want to highlight the important clinical points. So triglyceride is transported as chylomicrons and cholesterol is transported as cholesterol esters in LDL and HDL. Okay, so out of the lipoprotein, everything is atherogenic apart from HDL. HDL only non-atherogenic. These are the secondary causes of hyperlipidemia, drugs, metabolic syndrome, hormonal imbalances, anorexia nervosa, and all. Okay, so when to check a lipid profile for a healthy adult? Some advisory committees say you have to start from 20 years. So 20 years you have to start. But some task force, preventive task force say you can start from 45 years in a healthy female and from 35 years in a healthy male. Okay, so this is the the norm. But when you see a patient, when a patient comes to you, when do you think of checking a lipid profile for them? As I said, men over 35 and women over 45, and also all patients, as I said here, to about 20 years, regardless of the age, because it's that prevalent. It's a very common disease. And also in all diabetic patients, hypertensive patients, smokers, obese patients, family history of heart disease, and some of the inflammatory disorders like SLE, psoriasis, chronic renal failure, and also in HIV patients with antiretroviral therapy. So these are the values, cutoff values that I have just added for the reference. Okay, now the pre-discussion question is, in addition to being placed on a statin, which of the following treatment has been shown to reduce the risk of cardiovascular disease? Is it in addition to statin? Is it niacin? Is it the fibrate, cholestyramine, ezetimibe, or none of the above? Okay, we will move on to the lecture, and as we go on through the lecture, we will find the answer for this. Okay, so key concept in lipid lowering treatment. When a patient comes to you, you have to identify the cardiovascular risk factor of this patient. That is the most important thing. Then you define what is the LDL target for this patient, and you treat the patient. Okay, so when you treat the patient, you identify what is the suitable lipid lowering therapy for this patient. So these are the 3 key ingredients in treating the dyslipidemia. You identify the cardiovascular risk factor, and you identify the LDL target, and you treat the patient. Okay, so this pyramid, you all can see lifestyle changes important. The lifestyle interventions are very important, that almost runs parallelly with the medical treatment. So without lifestyle treatment, medications won't answer. So the first line antilipidemic treatments are statin, and now there are emerging treatments, non-statin therapy. They are gaining much more important, even though in Sri Lanka we don't have access to those medications. Those medications play a very important role in the management of dyslipidemic patients. We will see what are the new antilipidemic drugs are. So, but as clinician, lifestyle important is very important, because if I'm not bothered about the lifestyle modification of my patient, if I don't think about the lifestyle modification of my patient will also not bother about it. So I by myself should stress, while writing statin for the patient, I have to stress the lifestyle changes for the patient as well. So because these days there's a lot of discussion about lifestyle modification, because we will come to that, because why they are important, I will tell you, and then we'll move on to the next slide. The principle is, as I said, you have to identify the magnitude and the duration of problem, and you cause adequate LDL reduction. That is the important thing. The goal approach to LDL management is total CV risk reduction. So the benefit of LDL reduction is not specific to statin therapy, as I said. No lower limit of LDL is defined now. Lower the better. So we all have to remember one important point of this lecture is there's no lower limit for LDL now. Lower the better. Don't stop your statins, first of all, when the patient reaches target level. So you have to continue statin therapy. That is the other important message of this lecture. So which patient should be treated? My entire lecture is summarized in this slide. So you have to identify the patient's lifetime risk of experiencing either heart attack or stroke. Then, if this patient doesn't have a risk, probably he doesn't need a statin. And the other point is, irrespective of the risk factor, if a patient comes to you with a LDL level of more than 190, you have to treat the patient. For all others, you have to risk stratify them. So what are the strategies? We know either primary prevention or the secondary prevention. Why we do, by doing that, we risk stratify the patient. As I said, we have to identify the low risk patient, moderate risk, high risk, and very high risk patient and treat them according to that. Very high risk patients are the patients who have had at least one episode of atherosclerotic cardiovascular disease in the form of MI, stroke, or peripheral vascular disease. So they are very high risk patients. And also diabetic patients with multiple cardiovascular risk factors or diabetic patients with end organ damage are high risk patients. So these patients anyway need statin. Other patients, if they have one risk factor, they are low risk. Moderate risk, 2 risk factor. And high risk patients have 3 major atherosclerotic cardiovascular disease at the same time. Diabetic patients without end organ damage or minimal risk factor also high risk. Anyway, diabetes is a high risk patient. When you look at the LDL target from low risk to high risk, it's always below 100. When you come to the high risk patient, it is 70. So that is the target first you have to try to achieve in these patients. So we almost always talk about the LDL target nowadays. Not total cholesterol, but there are the total cholesterol, the HDL ratio is also important. But when it comes to clinical practice, talking about LDL and achieving LDL target is easy for the clinician and patient. So so as I said in my first step, we have risk categorized the patient. So this is the American College of Cardiology risk categorization. That is the same as American Association of Clinical Endocrinology. So all the guidelines are the same. We have to risk stratify these patients and we have to identify the high risk group and also very high risk group patient for the targeted treatment. And in secondary prevention, what are the major cardiovascular risk factors that patient might have had in his life? Either acute coronary syndrome or ST elevation myocardial infarction, stroke or peripheral vascular disease. These patients anyway need treatment. Other high-risk conditions that I have mentioned, chronic kidney disease, smoking, diabetes, hypertension, and if the patient has had PCI or the bypass surgery, patients with heart failure, all are high-risk patients. So this is the important thing that we have to, this is the main message, the second message for the of the lecture. The atherosclerotic cardiovascular disease, statin benefit groups. If the patient is more than 20 years and less than 75-year-old, at least once in his lifetime, if he has had an ASCVD event, that patient needs high intensity statins. And the second group is, as I said, irrespective of anything, if the patient has more than 20 years, LDL level is 190, that patient needs high intensity statin. If diabetic patients, 45 to 75 years old, anyway diabetes is a high risk condition, as I said. If there are no other risk factors or end organ damage, you have to give moderate intensity statin. If they have end organ damage, high intensity statin. And others, if the 10-year cardiovascular risk is more than 75%, and if they are between the age 40 to 75, you have to start at least a moderate intensity statin. So this is the nutshell. This is the main the component of statin treatment. So irrespective of the cardiovascular disease, first 1, 2, 3 groups should be treated, and the others, when you risk stratify, if the risk is high, you start with a moderate intensity statin. So as the risk go on, as the risk increases, you can see the target LDL level is also coming gradually down. I will tell you why this is so. Earlier it wasn't the case. Now they say lower the better. And how do we risk stratify the patients? We give a score by using a system called SCORE. This score estimates the 10-year risk of first fatal atherosclerotic event as a heart attack, stroke, occlusive arterial disease, or sudden cardiac death. These are the group that I have highlighted here. So if the patient has already a cardiovascular disease or LDL more than 70, patient who have diabetes, and 10-year risk more than 7.5%, all should be treated. So these are the risk charts we have used earlier, but now it's online. So it's the American College of Cardiology ASCVD risk calculator. This is the one that we use now when the patient comes. So it gives you, it sometimes slightly underestimate or overestimate the risk, but still we use it to calculate the 10-year cardiovascular diseases of the patient. It is very easy. So if you add the details of the patient, it automatically calculates, and it is also now, it is specific for the subgroups. It asks for the race of the patient, either black or non-black, and we can calculate the risk. So this is what we are using now for our patients. As I said, after using this, you give a score. That is the score there. So if it is a low risk, it's less than 5 to 7.5 is borderline, intermediate risk, and high risk patients are more than 20. By that time, the high risk patients have developed at least one atherosclerotic cardiovascular disease. So all the other patients, before starting, you have to have a patient clinician discussion, like the benefit of statins, the cost effectiveness, and the potential side effects. So this is, again, I am coming back to the original point. In primary prevention, if the cardiovascular disease is more than 7.5, you start a moderate intensity statin and look for the presence of risk-enhancing factor. There are risk factors and risk-enhancing factors. What are those risk-enhancing factors? These are the risk-enhancing factors, like metabolic syndrome, history of preeclampsia, premature menopause, high-risk ethnic groups like South Asians, and also presence of ankle brachial pressure index less than 0.9, and lipoprotein little a presence, all are risk-enhancing factors. So if any of those risk-enhancing factors are there in a patient who is on a moderate intensity statin, again, that patient is a candidate for high-intensity statins. Again, diabetes mellitus. As I said, if the patient has diabetes without end organ damage, 40 to 75 years old, moderate intensity statin. If they have high risk features like high intensity statin, the high risk features like end organ damage, you have to go for a high intensity statin. In secondary prevention, as I said, you always start with a high, maximally tolerated dose of high intensity statin, and the aim is to achieve LDL targets by 50%. In the secondary prevention, always, as I said here, you can see the target LDL should be less than 70. How do you achieve this less than 70? If you can't achieve that less than 70 LDL dose by statin alone, you can add always ezetimibe. If ezetimibe is freely available now, if ezetimibe is not enough only, you have to go for the third agent, that is the injectable non-statin newer agent. As I said, the high-risk conditions, because I'm stressing these things again and again, because to understand the things more easy. This slide actually summarizes all what I have stated now, and that is the summary. Okay, now the drugs that decrease cholesterol and decrease ASCVD risk in primary prevention, these are the three drugs that reduce the cardiovascular disease of the patient in trials. First one is the statin, second one is the ezetimibe, third one is the PCSK9 inhibitors. Those are injectable, alirocumab and evolocumab. So these are the pathways that drugs act. You all can see statin inhibit the cholesterol synthesis, and ezetimibe inhibit the cholesterol absorption, And the PCSK9 is a protein that is inhibited by PCSK9 inhibitors. Because of that, there is LDL receptor degradation is prevented. So evolution of dyslipidemia treatment is, these are the newer agents now we talk about more and more, but unfortunately, these agents are not available to us. Okay, do patients with low LDL level still benefit from non-statin treatment? Yes, even if the patient's LDL is low, they still benefit from non-statin treatment. That is proven by these two trials. IMPROVE trial is for the ezetimibe and Fourier trial for PCSK9 inhibitors. Both of them showed the lower the LDL level, more the CV risk reduction. So the lower the LDL level, more and more you get CV benefit, cardiovascular benefit. Now we will know the numbers. Moderate, high intensity statin bring down the LDL by 50%. Moderate intensity, 30%. Statin and ezetimibe bring down the LDL by 65%. And if you add a PCSK9 inhibitor alone, it causes 60% reduction. Statin, PCSK9 and ezetimibe all together, it can cause 85% reduction in the LDL. Why we are talking about all these very, very low LDL levels? I will come to that. There is a scientific basis. As you can see, over the time period from 1998 to now 2024, the LDL level for the patients with for the prevention and the primary and secondary prevention, LDL levels have come down very low, very, very low. This is the reason. As you all can see, when the LDL level is 100 and when the LDL level is brought down to 70%, there is a 10% reduction in cardiovascular event. When the LDL is brought down to 50%, the 50, there is 13% reduction. And when the LDL is brought down to 20, that is the purple line, there is a 30% reduction in cardiovascular event. That is proven in research. You all can see this New Zealand white rabbit, that the LDL level of New Zealand white rabbit is 10 to 11. That is the only animal where that the cholesterol plaque is 0. All the animals have cholesterol plaques in their blood vessels. This is the only animal which has a 0 cholesterol plaque. That LDL level of the New Zealand white rabbit is 10. And we will know, see that when you compare the hunter-gatherers LDL total cholesterol level with the modern human cholesterol, it is around the range of 100 to 140. Our cholesterol range is around 200. And other wild primates like baboons and all, their cholesterol is closer to the hunter-gatherers cholesterol level. And the wild elephant, bears cholesterol is between 70 to 140. So the modern human's total cholesterol level is close to 200, mainly because of the diet and sedentary lifestyle. Okay, so how safe is a very low LDL? That is a most important question to address. So if we bring a very low LDL level by statin alone, the side effect of statin did not change irrespective of the cholesterol level. Even if the cholesterol is very low, there's no statistical difference between the side effect of statin. Muscle side effect, even everything, the liver enzyme, it didn't statistically change. The lower the LDL level, cardiovascular benefit if the patient is more, but the side effect of statin, there's no significant difference. That is another important point to consider, because patients come and ask you, if my cholesterol level is very low, how safe am I? Is it very safe to bring my cholesterol level, that LDL level that low? Some patients think and come and say, my cholesterol level is very low. I have weakness, I have lethargy. They come and tell you various things. So this is a very important thing to know. Irrespective of the LDL level, side effect of the statins are same. And statins are there now for more than a quarter century. It is the first trial of statin is published in, that is 4S trial, that is published in 1994. Now 2024, it's now 30 years statin. So what the safety and the side effect profile of statin is very well studied now. So I will come to the side effect profile of statin. So the high cholesterol is, LDL is bad, average is not good, lower is better, but lowest is the best in terms of LDL. So what happens when you bring down the LDL to a very, very, very low? These are the intravascular images of the coronary with the plaque. It causes the plaque shrink. It thickens the capsule of the atheroma, thereby it prevents rupturing of the atheroma. So that's what happens. This is the OCT image of the inside the coronary artery. It causes the shrinkage of the coronary plaque and thickens the fibrous capsule, thereby reducing the risk of further rupture. This is another important point. As you bring down the LDL cholesterol, cardiovascular risk also go down exponentially. There's no plateau phase for the cardiovascular risk. The lower that you bring the LDL level, the cardiovascular risk also go down further. It doesn't stop at any point. So that is also, this is published in I think Lancet, and it is from the Fourier trial which used the injectable agent. So as long as you bring down the LDL, your cardiovascular disease is also more. Yes. So why am I talking about all these things? Because the cholesterol accumulates, LDL accumulates over the life. It causes a toxicity. That's why we call there's something called cumulative LDL toxicity. What is a cumulative LDL toxicity index? That is given as number 8. This is the number. When you reach this number, you get your first atherosclerotic cardiovascular event. So when you reach this number, you get your first event in your life. How does it determine? It's determined by your LDL cholesterol level. This level can be brought down. That means you can get the disease earlier by smoking, diabetes, and hypertension. It can be brought up by good lifestyle intervention, female gender, and all. So if this is a cumulative index, that is, you develop the first event. If your cholesterol level is continuously, LDL level is continuously 200 in your blood, you develop your first event at 40 years. If your level is 120 LDL level, you develop your first event at your 60 years. If your LDL level is continuously 80, it takes 80 years for you to develop your first event. So what is the aim? Prevention of first atherosclerotic cardiovascular event in an individual. So if you maintain your LDL low at a very low for a long time, the first event you may develop is at 90 years. So that is the aim. That is the aim that we are talking about. Okay, so in summary, as I said, patient with prior ASCVD, they have a very high risk to develop secondary events. Go early. Why? Because of this. Go early in reducing LDL. Target LDL is always now below for high-risk patient. It's 70. 3 steps. High intensity statin. It's not enough. Ezetimibe and then injectable. Don't worry about too low LDL. Brown and Goldstein, who did most of the researches in LDL and they won the Nobel Prize, they say physiological level of LDL is 25 to 60. So focus on low LDL. Okay, now the important few slides. Can we reverse our coronary artery disease? Can we reverse our atherosclerotic cardiovascular disease? Yes, that's what I'm going to talk about. So now they talk about not treatment, reversal of your cardiovascular disease. It is possible. It is shown in the researches, and I will tell you what are these. This first trial, which talked about reversal and regression of coronary atherosclerosis, is asteroid type. How do we do that? We all know this: lifestyle and pharmacological treatment. How intense? That is the important thing. How intensively you have to do it. You can do this by lifestyle alone, but it's very difficult. You have to dedicate a lot of time for that. But still, reversal of coronary plaque is possible. That's why with lifestyle, you need pharmacological treatment. Again, we know all this: good diet, stress-free, and exercise. How frequent, how intense? That is again a problem. Because if you want to go for this lifestyle strategy alone as a plaque regression strategy, you have to work very, very hard. Now, Then we will move on to the plaque regression strategy, how we can achieve on diet alone. So the available data, they have done coronary angiography and shown, but all these are non-randomized trials. These are anecdotal evidence and longitudinal data. In 1998, Dean Ornish, that is the first cardiologist who published a data with diet alone, you can reverse your coronary plaque. He followed up 48 patients who were put on vegetarian diet with a total fat intake less than 10% of the calorie. So that is the secret. Vegetarian diet with a total fat intake less than 10% of the total calorie, and Medicare approved lifestyle changing program. So they say you have to have the cardiac rehabilitation. That is more important. That is the important part of cardiology, which most people do not touch. Marvelous improvement can occur with cardiac rehabilitation. Fortunately, we have a cardiac rehabilitation unit in Kandy National Hospital. So the Medicare approved cardiac rehabilitation program, you have to do 2 hours a day, 3 days a week. That is 6 hours, a lot. Some people may not be able to dedicate that much of time. But if the patients were put on vegetarian diet and total fat intake less than 10 and the Medicare approved lifestyle program, he has shown in his longitudinal data and follow-up angiography, there is plaque regression. And the other one, Eisenstein, he adopted a diet, vegetarian, plant-based diet with zero fat. In his follow-up longitudinal data and angiography showed plaque regression is noted. This is the book which is written by him, How to Prevent and Reverse Your Coronary Artery Disease. You can read this book. It is the book which has a lot of scientific basis for the diets and why vegetarian diets are important, how you can do the plaque reversal. So if you can get this book, it's better to go through this book. And as I said, regression of plaque can be done with exercise and IVUS studies. As interventional cardiologists, we do intravascular imaging and we assess the plaque characteristics. And with extensive exercises, plaque regression has occurred. And in the athletes, it has been shown as they have a calcified coronary plaques. Calcified plaques are more or less stable. And in sedentary individuals, the plaques are mixed type. That means low attenuation plaque means that plaque is very easy to rupture. Okay, so when you move on from sedentary lifestyle to the other end, the moderate to vigorous exercise, your plaque regression happens. But when does it happen? It has a limit. So you have to try hard. Some activity is always better than nothing. So that's why for sedentary individuals, we say even if you can't do the proper moderate or vigorous exercises, move around, always be active. So some activity is always better than no activity. And we have moved on to the pharmacological agents. Only agents proven to cause plaque regression is statin. The other one is ezetimibe and PCSK9 inhibitors. All the others have controversial evidence, and there's evidence for aged garlic extract also. But it is a small study. They have shown aged garlic extract also can cause some of the plaque reversal. Other one is fish oil. Fish oil, a lot of patients use fish oil. So what fish oil, what to use, that is a question. So fish oil, there are two types of fish oil, that is EPA and DHA. EPA is the purified form of fish oil, eicosapentaenoic acid, and the DHA is the docosahexaenoic acid. But the commercial fish oil preparations have both. Both of the physiologies are different because DHA is concentrated in the brain and EPA is concentrated in the blood arterial endothelium, and it prevents inflammation. So this is the purified form. If you want to take or if you want to give your patient, this is the form, not the commercial fish oil that is sold in supermarkets. So it has been shown that taking 4 milligrams per day causes coronary plaque regression. But the problem with the fish oil studies are they have used mineral oil in the control arm to modify the results of this fish oil. So the control arm, they have used mineral oils to modify the outcome of this fish oil. So that's why the fish oil is always controversial. And colchicine. Colchicine also, they talk a lot in the future. It can be a future because it's an anti-inflammatory agent and it causes reduction in the inflammation of the coronary endothelium. And in the CT coronary angiogram, it has shown that it regresses low attenuation plaque and modifies plaque. And as I said, there's no evidence for niacin and antihypertensive agents did not show plaque regression, but aged garlic has shown some evidence of plaque regression. Okay, how do we identify plaque regression? All this time, they have shown angiographical evidence of plaque regression. But now, from angiography and intravascular imaging, we have moved on to CT coronary angiography. Being an interventional cardiologist, I always talk about CT coronary angiogram because that is the future. Because we can incorporate CT coronary angiogram for management strategy because we can identify the high-risk plaque features in CT coronary angiogram. According to that, you can aggressively modify your treatment. So in future to come, what we do is we do CT coronary angiogram as a baseline. You treat the patient for 6 months and again you do the CT angiogram because now it has moved on to 125 slices to 250 slices. So the radiation risk is very minimal and non-invasive and you can modify your treatment. And also one important point that I have to highlight. Now if the patient's atherosclerotic cardiovascular risk is more than 7.5, but he's not a diabetic, he's a non-smoker, but patient also not sure about statin therapy. He doesn't want to take statin. He says, if we say that your risk is 7.5, but the patient doesn't want to take statins, what do? You do a CT coronary angiography. If the calcium score is 0, that patient doesn't need statin. So you can leave that patient and monitor alone. So if the patient's cardiovascular risk estimation can be more than 7.5, but non-diabetic, non-smoker, patient doesn't want to take statin, what you do is you do a CTCA and calculate the calcium score. If the calcium score is 0, and for females, they say the strong evidence is carotid intima media thickness, that is also normal. That patient for the next 5 years, very unlikely to develop the first cardiovascular disease. So you can keep that patient without starting statins. Okay, so why we talk about plaque regression strategy? We all know the cholesterol builds up inside the arteries and it ruptures. When it ruptures, the first cardiovascular event occurs. So until that is the natural history and this is the treatment plan that we have seen now. Until that, it's primary prevention and after rupture, it's secondary prevention. So what we have to do for the plaque regression, you have to target early and hard. This is the secret. Why we are talking about very low level of LDL is up to 90, after LDL level of 90, there's plaque progression. And 90 to 60, there's no change, plateau phase, plaque stays like that without any decrease or increase. But below the level of 50, it starts regressing. That's why we talk about low LDL level now. The lower you bring, the more the plaque regress. So that's how you reverse your coronary artery disease. So the below 50, plaque starts regression. Until that, there's no regression. So that's why you have to aim at very, very, very low LDL level. So this is the summary of what I said now. Plaque regression is possible. That is an important motivating factor. Aggressive LDL targeting is very important. If the high intensity statin benefit outweighs the risk, you have to always, if the addition of non-statin cholesterol benefit outweighs the risk, you have to always go for non-statin. So this is the PCSK9 inhibitor mechanism of action. These are the LDL receptor. They make more and more LDL receptor available by preventing the degradation. So more and more LDL particle can be engulfed and degraded. So the LDL level can be brought to very low level. So we know the answer. Now, ezetimibe. Ezetimibe prevents with statin further cardiovascular risk. If you can't achieve your target levels with LDL, you always LDL level with statin, you always start on ezetimibe. It is freely available. You start with 5 and then you move on to 10. So a few words about lipoprotein lipidase. It is common in little a. It is common in South Africans and South Asians and Africans, and it increases the cardiovascular risk. When this is present, your cardiovascular disease is doubled. You get a first event at younger age because it's pro-thrombotic and pro-atherogenic, both. So it causes the earlier development of coronary event, and statins have not been shown to reduce LDL level. So the newer agents, again, these are the ones which are the future for targeting management of lipoprotein little a. Few words about bempedoic acid. Bempedoic acid is a new agent that is not available for us in Sri Lanka, but it is in the same pathway as statins to reduce the cholesterol. So if your patient is statin intolerant, if you can use bempedoic acid as an adjunct to diet. I have few patients because recently I had a patient, 50-year-old diabetic lady, small male, but she has all three coronary arteries stented. We started on high dose statin. She had elevation of liver enzyme. Then we started her on ezetimibe. Liver enzyme doubled, and she has been diagnosed as DILI, drug-induced liver injury. So I had to stop it. After putting 2-3 stents, I had to stop all anti-lipidemic drugs together. So for a patient like her, bempedoic acid is the best option. So we are here now with the advancement of treatment and all, we are seeing more and more patients with complex coronary artery disease, complex treatment decisions, and we need more and more of these agents. Unfortunately, this is not available. So yeah, that is an important point. As I said, European College of Cardiology, American College of Cardiologists, endocrinologists, all stress the low LDL level. Okay, so now we have come to the risk-benefit ratio. We are at the level of talking about the safety of statins. So the benefit of bringing the low LDL, it prevents the coronary artery disease progression, and thereby it statistically reduces the CV death, MI, and stroke. But there are potential side effects of statins. The first concern about the statin is it causes new onset diabetes. So that is the biggest problem now, the recently emerged biggest problem about statins. So the first trial in statin, that is the Jupiter trial, which used rosuvastatin, they have in the meta-analysis of Jupiter trial, they have found more and more patients have been diagnosed with new onset of diabetes with the usage of rosuvastatin. Why it happens? The mechanism statin cause, the mechanism by which statin cause diabetes is largely unknown. But what they say is, if you are a high-risk candidate for the development of diabetes, and if your glycemic levels are close to the development of the cutoff value of diabetes, you might end up as having diabetes when you get statins. So the moderate intensity statin risk is 10%, and it can even go up with high intensity statin. So that is the problem. But still, the number need to harm is 100 to 200. That means you have to treat 100 to 200 patients with statin to cause one statin-induced diabetes. So still, the risk, the benefits outweigh the risk. So the number need to harm is 100 to 200. That's why they are still stressing on statins. That is one thing. And then there's this concern that statin causes subarachnoid hemorrhage and intracranial hemorrhage. So what the evidence says, statins are protective in terms of subarachnoid and intracranial hemorrhage because they are the donors for nitric acid oxide for the endothelium. But when the patient is non-adherent, when the patient withdraws statins, at the same time, they are non-adherent not only for one drug, they non-adherent for so many drugs. At the same time, if they withdraw their antihypertensive also, the cerebral endothelium undergoes a shear stress that causes rupture of the endothelium and end up with subarachnoid hemorrhage. And there's no evidence for cognitive impairment, renal failure, and cataract. There's no data, no evidence that statin cause cognitive decline or cataract or renal impairment. So these are the two concerns, and especially the diabetes about statin. And the small side effects will come. So, as I said, there's no difference in statin side effects when compared to LDL level. We talk about these side effects separately because this is important for the patient management. We have to know to whom to start statins because of the risk of diabetes, especially rosuvastatin, atorvastatin, and pravastatin are the drugs which are known to cause drug-induced diabetes. Yeah. So, the high intensity statins, only two, atorvastatin and rosuvastatin, and the moderate intensity statin is atorvastatin at 10 to 20. So these are the structure of statin. That is also important. There are naturally derived statins from fungal sources, and others are purely synthetic statins. So atorvastatin and rosuvastatin is purely synthetic statins. Atorvastatin is lipid soluble, and rosuvastatin is hydrophilic. So when there's a lipid soluble drug statin, the muscle side effects are more with lipid soluble statins. Then patient, because of the easy diffusion and easy concentration, they can cause more muscle side effects than the hydrophilic statins. You can see LDL reduction by the drugs. The atorvastatin is the purple line, and the rosuvastatin is yellow color line. Rosuvastatin causes less muscle side effect than atorvastatin because of the hydrophilic nature of the rosuvastatin. So what are the problems with statins? Statin non-adherence, statin intolerance, and despite maximally tolerated dose of statin, you might not be able to achieve the target LDL level, and the statins can cause SAMs, that is the most prolific side effect of statin, that is statin-induced muscle side effects. So these are the other effects of statins. When you change a statin or increase the dose, you have to do a lipid profiling 4 to 12 weeks, and then you follow up every 3 to 12 months, depending on the target value. So what is statin intolerance? Patient may not be able to tolerate any dose of statin, that is complete intolerance of statin, or patient might be able to tolerate statin at a lower dose which is required than the dose which to achieve the target LDL level. So patients, 5 to 12, 20 patients are statin intolerant, but usually the statin intolerance is as a result of perception or expectation. Some patients expect that if I take statin, I will develop these symptoms, and then they come to you and complain. So, but actually there's a subset of patients who are really intolerant to statin exists. That's why we need other agents which target LDL. So that is the need for the newer agents. When the patient is statin non-adherent, their coronary artery risk doubles. What are the factors that cause increase the myopathy? Hypothyroidism, renal failure can increase the risk of myopathy, and the drug factor, I said lipid solubility, increased dose can increase the side effect of statin. So when the patient complains of severe muscle symptom, what you have to do? You have to stop statin first and do CK, creatinine, and urine analysis for myoglobinuria, because severe muscle symptoms, you have to exclude rhabdomyolysis. That is the most other important message during statin usage. So, okay. So when your patient develops SAMs, you have to see statin-induced muscle symptoms. You have to see, because of that, whether the patient has significant functional impairment or impairment of his lifestyle. If it is so, you de-escalate or stop. If not, you continue. Once you de-escalate, if the patient feels better, what you have to do is you have to re-challenge the statin at a smaller dose or different statin group, as I said. And also, you can use an intermittent dosing of statin, like 3 days a week, because still it's beneficial. And you have to do the CK levels of the patient to assess where you are and what sort of muscle injury is that. Okay, so what are the strategies to mitigate the statin-induced muscle symptoms? You go for a low dosage or different statin, intermittent dosing, or naturally derived statins like simvastatin you can use. But there's no supplement, no evidence for supplement like CAR-Q or vitamin D. CAR-Q or vitamin D reduce these muscle symptoms. So there's no evidence that vitamin D or CAR-Q, coenzyme Q can reduce the symptoms of this statin-induced muscle injury. And intermittent daily dosing is, as I said, still beneficial in reducing the LDL cholesterol. Okay, statin in older individuals, still above 75 years old, moderate intensity statin is still beneficial in terms of reducing the coronary events, because by 75, most of the people must have developed either one atherosclerotic cardiovascular event. So here we have to always target secondary prevention. Okay. Lifestyle modification, the recommended time period for the exercise is 150 minutes per week, either moderate intensity exercise or 75 minutes vigorous exercise that you have to engage. As I said, some activity is better than nothing. This is the Just5 trial that I have to mention. It is the nurses' healthcare follow-up study. They have followed up 770,000 males and females for these factors: smoking, BMI, 30 minutes of activity, moderate alcohol, and healthy diet, because this was done long time back. And if they haven't followed any of those things, their life expectancy at 50 years is 29 years for females and 25 years for men. But if they have followed all these steps, their life expectancy at 50 years goes from 29 to 43 for females and 25 to 37 for males. Now we have come to the diet, another controversial point. As you all know, vegetables, legumes, and whole grain, all of these things are beneficial, and you have to replace the saturated fat with mono and polyunsaturated fat and reduce the cholesterol level and sodium. But which diet is better? Either there are a lot of diets now: portfolio diet, paleo diet, keto diet, Mediterranean diet. So every diet has its own benefit and drawbacks. But in terms of cardiovascular benefit, a lot of research evidence say that Mediterranean diet is better than the other diets. And here, this study is called QUICK study. They have followed up 31 patients on low-fat, whole food, plant-based diet. Now they are more and more stressing the importance of plant-based diet in prevention of coronary artery disease and also atherosclerotic cardiovascular disease, because they say more than the animal fat, plant-based diet are beneficial for the regression of coronary artery disease. So when you follow up these patients on this diet, they had reduction in systolic and diastolic pressure, serum lipids, and also weight circumference, HbA1c, and CRP. The one important point is independent of the amount of meat consumption, open flame or high temperature cooking and high doneness for the red and white meat is associated with increase in hypertension. Even that is true for fish. If you cook meat in high temperature, it becomes harmful. That is true for fish as well. Okay, saturated fat, we have to, for the coronary plaque regression, saturated fat should be less than 7% of the calorie intake. And one important point about nuts. Nuts are very beneficial. They have good quality protein, mono and polyunsaturated fat. But did you look at the energy value of 100 grams of almond? It is 570 kilocalories. When you do cycling, moderate intensity cycling for 30 minutes, you burn only 260 calories. So almonds are good for people who work out and do exercises. If you sit in front of the computer or TV and think almonds are good for your heart cardiovascular benefit and take a lot of almonds or peanuts, you will end up with a cardiovascular disease. That is the other important point. Another final trial that is called Mount Abu trial, which is a famous trial, which they have participated 123 patients. They have given vegetarian diet, moderate intensity aerobic exercise, and for the stress relief, Raja Yoga approved medication. They have given intensive treatment for 7 days, and they follow up every 6 months for 2 years. They have shown 10% reduction, the follow-up angiography, 91% of patients show 10% reduction in their coronary plaque. So to achieve a reduction in coronary plaque, you have to have more than 50% adherence to your lifestyle and diet. That is most important. And the key message is that now we are stressing on more important plant-based protein, Mushrooms are better, legumes and seaweeds are better. And also, overall, for the triglyceride reduction and the LDL reduction, you have to cut down on your energy intake, like sugar, meat, and also energy drinks. And always there's controversy about the dairy products, because most of the saturated fat come from the dairy products. So this is the Mediterranean diet pattern I said. Now, as I said, that inflammation is most important. Statin cause reduction in the high sensitivity CRP, and also there is evidence that fish oil can cause reduction. Purified form of fish oil can cause CRP reduction. So, okay, a few words about fish oil. Fish oil, commercially prepared fish oil, not only as I said, the purified EPA form is only 21%, and it has a lot of saturated fat and other fat. So, actually, taking commercially prepared fish oil is harmful. You can end up with coronary artery disease. Then patients bring you big bottles that they have got from either Australia or US and ask whether it is safe to take. So, these commercially prepared fish oil have this. And the other thing about that is that they have this lot of oxidized lipid that is very harmful. And these fish oils are prepared by farm cultured fish. They have a high level of PCB, dioxins, and heavy metals in them. So actually, whole fish oil is harmful. But if you want to give your patient, you have to give this purified EPA form, which is 4 grams per day. And there's no time. There are a lot of controversy about coconut oil, seed oil, and eggs. And this is I have come to the conclusion of my lecture. And thank you so much for the time.